Hi, everybody. Thank you so much for taking the time out of your busy days to attend our continuing professional education webinar today, titled Maximizing Nourishment Throughout the Progression of ALS. I'm Laura Doherty from Functional Formularies, and I'm excited to introduce our two guest speakers today. First up, we have Janae Arnaklev, who is a certified family nurse practitioner that has close to 20 years experience in primary care. Her passion is a combination of research and patient care. During her training at Johns Hopkins University, she participated in research with hypertension in Korean Americans. She is a National Health Service Corps scholar who worked with the underserved population in inner city Baltimore. Prior to her current role at the Johns Hopkins University Center for ALS Specialty Care, Janae worked with the Healthy Aging Across the Lifespan and Neighborhood of Diversity with the National Institute of Aging at NIH. Janae's goal is to work with patients to maximize their function in whichever disease state they face, such as ALS, and empower patients with knowledge in their healthcare decisions. And our second guest speaker today is Stephanie Dobak. She's a clinical dietitian at the Jefferson Weinberg ALS Center in Philadelphia, Pennsylvania. In this role, she provides nutrition care to people with ALS and manages all enteral nutrition regimens at the ALS Center. Stephanie's ALS research has focused on standardizing nutrition care, discerning the ideal time for gastrostomy tube placement, implementing interventions to increase quality of life, and optimizing advanced care planning discussions. She is the co-founder of www.alsnutrition.org, the only website dedicated exclusively to dietitians treating people with ALS. Stephanie is also the co-chair for the Nutrition Subcommittee of the Northeast ALS Consortium and executive coordinator for the Dietitians in Nutrition Support Dietetic Practice Group of the Academy of Nutrition and Dietetics. So with that being said, ladies, I'm going to hand it over to you, Janae, to get us started.
Okay, great. Thank you so much and welcome everyone. These are our disclosures. And today we're gonna look at several things, describe the disease process of ALS and its impact on nutrition, navigate enteral nutrition challenges in the ALS population, and list ways to incorporate whole foods into the nutrition regimen of people with ALS. So ALS is a progressive motor neuron disease characterized by the gradual loss of voluntary muscle movement. In the majority of people with ALS, approximately 90%, there's no known cause, but in about 5 to 10% of people, there is a known genetic cause of ALS. And though there may be some obviously inherited link, only approximately 25 to 40% of these cases are identified by known gene mutations, and studies are ongoing to identify more genetic links. C9orf72, SOD1, TARP, DDP, and FUS account for approximately 70% of people with familial ALS. And with the disease progression, typically starts with in 1 to 2 regions of the bodies, sometimes in the arms or legs, sometimes in the bulbar region, which is the face, neck, swallowing, and speech. Very rarely can have it also start in just the respiratory area. But a person with ALS may lose their ability to speak, eat, move, and eventually breathe. And the average lifespan is approximately 2 to 5 years after diagnosis. So this is what we call an ALS functional rating scale. It's a validated tool that quantifies disease progression. It measures 12 aspects of physical functioning within 4 domains: the bulbar, fine motor, gross motor, and respiratory. It is a self-rated scale, so patients give a self-reported score between 4, which is normal, to 0, which is no ability. And the total score ranges from 0 to 48, indicating 48 being the highest function. And on average, people with ALS decline about 1 point per month. So there are currently 4 treatment options. There's one that's specifically for, that's not listed on this, but is also one of the treatment options. But I'll go through the 3 primary ones. Riluzole was one of the first ones to be approved in 1995. That is a glutamate antagonist, and it's oral, and people need to take it approximately 1 hour or 2 hours after meals, and it's taken twice a day. Edaravone was approved with IV use in 2017, and then an oral version came out in 2022. So it starts with a 14-day, and then maintenance is 10 out of 14 days with a 2-week off cycle. With the oral form, you're supposed to take it on an empty stomach in the morning, and then if you do eat, you shouldn't eat about 1 hour after. And then the third, which is Rilivril, or sodium phenylbutyrate taurursodiol, is the generic form, or the 2 components. It's a histone deacetylase inhibitor bile acid combination, and it was approved in September 2022. That you are supposed to take twice a day. One of the challenges of that medication is people have a lot of GI side effects. It's something that you mix with approximately 8 ounces of water, and it's something that people have a challenge with the taste. And as you guys can all imagine, trying to take the 3, and most of them or 2 of them out of the 3 needing to be on an empty stomach can be quite challenging for our patients, especially with the medications that also affect appetite and have GI side effects. The 4th one, as I mentioned, is actually specifically for people with the SOD1 mutation, and that one is called tofersen, which some of you may be familiar with, but that also is a ALS treatment option. And that is actually via intrathecal route, so that is not something that's really affected by food or I just wanted to mention that really quick. So next we're going to have Stephanie go over some more information about treatment options. Thank you.
Thanks, Renee. So given the lack of pharmaceutical options for ALS, many people with ALS turn to alternative therapies. And I personally don't blame them. They're desperate for anything that may help them combat the disease. Studies note that up to 80% of our patients are taking dietary supplements. And we know dietary supplements aren't regulated by the FDA. There might be drug nutrient or nutrient-nutrient interactions. So we want to be very proactive in asking our pals if they are taking dietary supplements and be mindful to give them the appropriate education. And if you're not familiar with the website below, alsuntangled.com is phenomenal. It was made by Dr. Bedlack out of Duke. It's a peer-reviewed, credible site. They go through the literature, they go through different case studies, they even go through forums, and they summarize the risks versus benefits of alternative treatment options. So they review different supplements. They even do other things like fecal transplant or gluten-free or ketogenic diets, and then other therapies such as acupuncture and stem cell transplant. Nutrition is very important in ALS, and I know that's why you're all here. Unfortunately, malnutrition is very prevalent, and the older studies showed that about 16 to 55% of people with ALS have malnutrition. And I'm thinking with the newer criteria from Aspen and the Academy and GLIM that this number is actually higher. And malnutrition is a prognostic indicator for survival. And malnutrition, lower weight, and weight loss is unfortunately associated with reduced survival time. Paganani et al. Noted an obesity paradox with pals in which there's this U-shaped association between BMI and mortality, with higher mortality being seen with lower BMI ranges, so less than 25. Then the mortality risk dips down with BMIs in the range of 25 to 35. And then the mortality risk again increases with BMI greater than 35. There seems to be this sweet spot with a BMI of 30 to 35 that's associated with the highest survival. So we know that's class 1 obesity, and that's why there's this paradox in that the general population, we're saying we don't want you to have a weight in that category. We want to go a little bit lower. But it indicates that people with ALS who have a little bit more weight on them seem to fare a little bit better and have longer survival. But it's difficult to diagnose malnutrition in this population given the current criteria from the Aspen and Academy. So starting at the bottom left with hand grip strength, we know the hand grip strength measurement may not be plausible depending on manual dexterity, and then any sort of weakness throughout the months may signify disease progression instead of malnutrition. Muscle loss is characteristic of the disease, and it also may simply reflect disease progression, although it might be compounded with malnutrition. I know I, as a clinician, have difficulty discerning if the muscle loss is from disease or malnutrition. So I think a little bit other studies need to be done in that area. Edema may be due to immobility because it's very common in people with lower extremity weakness. Oral intake may remain unchanged. So you might have your patient saying, I still eat the same, nothing's changed. In fact, I'm eating more, but I continue to lose weight. And that's just because it's compounded by this hypermetabolism. And along with that, the weight loss might just be indicative of the muscle loss from the disease process itself, though obviously we want to avoid weight loss of any kind, no matter its cause. Not listed on here, but one of the criteria of the Aspen Academy malnutrition criteria is the subcutaneous fat loss. And I think this might be, at this point, the best indicator of malnutrition in this population, given the other limitations of the other criteria. Dr. Roop Tandon did a study on this along with Dr. Karsarskis, and they noted that there was this overall survival with increased subcutaneous fat. So I think this might be an area of more study. And then Lopez Gomez noted that patients with a better nutritional state, according to SGA and GLIM criteria, severity classification of malnutrition were associated with having longer survival time. But I think at this point, it would be nice to see if we need an ALS-specific malnutrition screening tool or diagnostic tool. I think we need to better define malnutrition in this population and come up with a consensus. When talking about nutrition needs, we're going to start with calories first. 50% of people with ALS are hypermetabolic, and they're 5 times more likely to be hypermetabolic than their non-ALS peers. On average, measured resting energy expenditure is 20% higher than calculated using common equations such as the Harris-Benedict equation. And many of the common predictive equations are likely to underestimate calorie needs. You can use the Karsarskis equation. There's actually a calculator online, and this includes components from the ALS FRS-R, so it's specific to the ALS population. Or a lot of people use a weight-based equation such as 30 to 35 calories per kg. But at the end of the day, I think we just need to realize that this is a starting point. So especially for the people that are enterally fed and you can really determine how many calories they are getting on a daily basis, you have that starting point, whatever equation you use, and then you monitor their weight and see if you need to adjust it. So I don't want to put too much emphasis on the equations themselves because they're just a starting point. Interesting enough, 80% of people with ALS have no change in metabolic status throughout their disease progression, which I think is crazy. You would think that once they become less active because of the disease, they would burn less calories. But it shows that they remain hypermetabolic throughout the disease. And studies have sought to determine if the hypermetabolism is related to the gut microbiome or changes in the hypothalamus. but there weren't any association between those two things. Personally, I believe the hypermetabolism is related to increased respiratory effort, especially as the disease progresses, particularly if the patient is not supported enough in their non-invasive ventilation or they're not compliant. For protein needs, they are not well studied at all in this population. Please, if you want to do research, please focus on protein. And because it's not known if increased protein intake would mitigate disease-related muscle loss. There's a couple smaller studies that showed that increased protein didn't have an impact on the disease trajectory. In the absence of data, dietitians are using varying equations for protein needs. And the calculations range from 0.6 grams per kg up to 1.5 or 2 grams per kg. So we're a little bit all over the map, but generally people use 1 to 1.5 grams per kg. We just reviewed how important nutrition is, but unfortunately there's many barriers to adequate nutrition, causing people with ALS to only consume 84% of their calorie needs on average. And I know you see this in everyday practice, but this chewing difficulty, especially for our bulbar patients, in which their tongue is getting weaker and it's not able to move the food around. We have dysphagia, we have hypermetabolism that we talked about, self-feeding difficulty, communication challenges in which they can't say easily like, hey, can you get me a snack or can you bring me something? Everything's so much more effort. Fatigue, knowing that you have this finite amount of energy per day and it tends to putter out throughout the day. And so a lot of people get fatigued towards the end of the day and might skip meals, particularly dinner. Shortness of breath, knowing that whenever you swallow, you do hold your breath. So trying to coordinate eating when you are short of breath is rather difficult. Constipation is very common, so it is difficult to continue to put things into your body if nothing is coming out. Sialorrhea, or the inability to manage your saliva because of weakness in your mouth muscles. This could lead to dehydration over time just from constant drooling. Depression, we know that as much as this is a physical disease, it's very much a psychological and mental disease. And so knowing that you might just not want to eat just because you're so sad and depressed by this disease diagnosis. Decreased appetite could be related to depression, but it might also be related to other factors that we haven't quite quantified yet. Frontal temporal dementia is not uncommon in this population, and so if they have FTD, they might forget to eat or might forget how to feed themselves, even if they're capable. And then the decreased ability to shop and prepare meals, knowing that if your patient was the person that meal planned and went to the grocery store and cooked everything, to have their caregiver or loved one who maybe never did that really in their life to take over those roles on top of everything might make eating difficult. So talking about these nutrition barriers and causes and potential ways to combat them. Again, the hypermetabolism from the increased muscle demands. We want to combat this with high-calorie foods and oral supplements. Dysphagia, again, from the oral muscle spasticity and flaccid weakness. And you're going to work with your speech-language pathologist to discuss mechanically altered diets and if it's wanted and appropriate to talk gastrostomy too. Constipation, this is from a slew of issues from decreased appetite to truncal weakness, not being able to bear down during a bowel movement, to medication side effects if they're on opiates or iron supplement, inadequate fluid or fiber intake, and there's been some studies suggesting that there's an altered microbiome in this ALS population. So we want to address fiber. I say address fiber cautiously. I think fiber can either make or break you, especially for people that become less active. I think more fiber could really actually hurt them and compound the constipation, but we do want to address fiber and fluid intake and then discuss bowel medications to treat the constipation. Again, the mood disorders, fatigue, frontal temporal dementia, causing poor appetite and possibly skipped meals. So knowing that there's counseling and support groups available, and then different medications. And then lastly, the excessive saliva or sialorrhea. It's not so much excessive saliva, it's just the inability to manage the saliva that you have because you have weakened oropharyngeal muscles. And then we have medications and we can educate them on increased hydration. We know that nutrition show is not a one-man show. It is a multidisciplinary team effort. And I'm going to go over the different team members and their nutrition-related roles. And starting at the top, the dietitian, which I'm sure most of you are on this call today, and that you are providing the nutrition assessment and estimating needs. You're talking about different diets, how to improve calorie intake. You're helping manage their constipation with diet. You are discussing gastrostomy tube if it's appropriate, and if they do get a tube, you're probably managing the enteral nutrition regimen. We have our providers, our neurologists, our nurse practitioners, palliative care physicians, who are ordering medications for the symptoms such as constipation and sialorrhea and any sort of antidepressants. And they're also helping discuss and manage the enteral nutrition picture. We have our speech language pathologists who do swallow studies. They assess aspiration risks, and they suggest any sort of diet texture alterations. They also can provide communication strategies, particularly with our bulbar patients who lose their ability to speak. And along with that, we have our assistive technology specialists who specialize in communication devices. We have the pulmonologists and respiratory therapists who address respiratory related fatigue and help give some education on synchronizing the swallowing while breathing as well. We have occupational physical therapists who teach adaptive techniques for meals and also provide adaptive equipment for meals. We have our social worker, and I found this is a really hidden gem to help procure meals if there's ever food insecurity. So if you have those patients that are living alone, they're not able to easily get to the store, the social worker can help you get meals delivered to the home. And then the mental health worker who assesses any sort of mental health challenges and suggests appropriate treatment options. When we're discussing nutrition support, we know that G-tubes can provide safe and consistent delivery of nutrition, hydration, and medications. It often begins as supplemental. I know a lot of us try to promote G-tubes earlier in the disease when the patient is stronger, when their respiratory drive is stronger, and then as the disease progresses, usually the dysphagia progresses, in which they will need enteral nutrition to meet 100% of their nutrition needs. Observational studies have suggested a survival benefit with G-tubes. Other observational studies have suggested not. But at the end of the day, we are really lacking in randomized controlled trials in this area. But the indications for G-tube placement is insufficient nutrition or hydration, and along with that corresponding weight loss. If they're having chewing or swallowing difficulty, fatigue that's preventing adequate intake, so they're skipping meals. Prolonged meal time, so greater than 45 to 60 minutes, knowing that at that point, if they're trying to feed themselves or they're taking a lot longer to chew, they might be burning more calories than they're actually consuming. And then just talking about the compromised quality of life in that and feeling like a failure, not being able to get through a meal or just taking forever. And then the forced vital capacity of at least 50% of predictive normal value, although I will say this is based off older literature. The more recent literature questions this value, especially if it's with a dedicated interdisciplinary team, particularly a surgeon that works a lot with ALS patients. They have found that this FVC number could be significantly lower. I know in our clinic, we've provided G-tubes in people with FVCs less than 20% and had safe outcomes. When our patients do get G-tube, we want to talk administration methods and what might work for them in their lifestyle. So bolus or syringe feeds, they obviously are more physiological. They go in over 5 to 10 minutes usually. It reflects the typical meal pattern. They're inexpensive, it's portable, you can take it on the go with you, but there is the con that requires more manual dexterity that might be limiting in some of our patients if they have to hold the peg in the syringe with one hand and try to pour in the container of feed with the other hand. There is this product, not that I'm trying to promote different products, but the Bolink decap, in which that it connects the enteral nutrition product directly to the G-tube, so that way they can only have one hand and hold up the feeds with the tube at the same time, and it decreases the risk for spilling. We can have our intermittent feeds or gravity bags. The pros, again, these are more physiological. They can go over 15 to 30, possibly even 40-minute meals. It allows for slower administration, so this might improve GI tolerance for some of our patients. And then I think a big perk is that it allows the caregiver freedom during their mealtime. So that way they can set up their loved one with their gravity bag, and then they can also eat their meal with them, and that way it frees up their hand from doing a bolus feed. The cons of gravity bags are that they are less portable. It has an IV pull or something similar to hold the bag, and it does require more equipment. And then lastly, we have our pump-assisted feeds, so our continuous or cyclic feeds. And this does allow for slower administration, again, to improve tolerance for our patients that have had GI issues. It requires less manipulation of the feeds, which is nice. So you just set it up and then you leave it to do its thing for hours, and then you come back and take it down. But it's the whole day, you just have to put it up once and take it down. And then also this allows caregivers more freedom during their own mealtime. The cons are that the pumps are less portable. There are backpack options, but it does require more equipment. And then especially for Medicare, it requires additional insurance justification. When we talk about G-tube's impact on quality of life in people with ALS, it is rather debatable. So I'm going to go over these 3 studies. The first study showed that G-tube placement actually decreased survival time by 46% and had no effect on quality of life. So the authors came to the conclusion that G-tube placement may have a negative effect on survival with no quality of life related benefit for people with ALS. The second study said, in conclusion, overall quality of life in ALS does not appear to change after non-invasive ventilation or PICC tube. And then the last study said patients who took high-calorie nutritional supplements via PEG stated a great benefit regarding weight stabilization and or quality of life. At the end of the day, these are very individualized discussions to determine if a G-tube is appropriate and in line with goals of care for that individual patient, but also their caregiver as well. And the overall goal is to promote quality of life when we're talking G-tube. If we can get some weight gain and stabilization, that's amazing as well. Anecdotally, I have seen G-tubes decrease meal-related anxiety by decreasing the fear of choking at meals or time or energy spent at meals. I will say the first thing now that goes through the tube is Relibrio. If you haven't tasted it yourself, it's as bad as all your patients say. So that's a big perk of being able to have the tube. It can decrease the burden of the caregiver spending prolonged time feeding the patient by hand. It's usually quicker to administer or set up the tube feed, but we know that the tubes aren't for everybody. And that brings me to this slide, that we want to make these discussions very patient-centered. And there's different factors that play into that. So culturally, there might be different cultural views around having artificially administered feeding and hydration. So, and then just who's involved in decision making. So knowing that some cultures have a very patriarchal structure within the family in which the lead male makes the decisions. In other cultures, such as some Asian cultures, they might not even want to know their prognosis. That to them brings them bad luck, so they might defer all decision making to their children. So it's important to know how culture might impact decision making and who we want to get involved in these decision making processes. Religious. Some religions believe that artificially administered nutrition and hydration is a basic or ordinary need that is mandated for all people. Others believe it is an extraordinary need or a medical measure. Some patients may really rely on the religious leader to make the decisions for them. So making sure when it's appropriate to ask if you want the rabbi involved or your priest involved or your imam involved. Regarding ethics, we know there's 4 pillars. So there's the autonomy, which is the right for our patients to make the decisions given all the information. And we do want to value their opinion, but we also want to weigh it with non-maleficence, which is do no harm, or beneficence, which is always act in the best interest of the patient, or justice, knowing that there are limited resources and we want to distribute them fairly. So making sure that we balance all those together. And overall focusing on quality of life and knowing that the definition of quality of life depends on the person. It really differs between each person. And so having that in the forefront of our mind, will this take to promote their quality of life. And speaking of quality of life, we know that quality of life suffers greatly when gut health is compromised. And so these are some common GI issues in people with ALS. So at the top, we have distension, nausea, vomiting, diarrhea. So we want to assess their medication and health history. And so knowing with the medication, we have Relyvrio on the market now, which unfortunately a side effect is bloating and diarrhea. Any sort of health history, seeing if they have IBS or something similar that might be exacerbated as part of the disease process. And then if they are on enteral nutrition, we want to talk about, is that the right feed for them? Is that the right administration? Should we switch to a slower rate or a different method? Should we try a different formula? There's, again, some studies showing that there is an altered microbiome. I don't think we're there yet to go to a probiotic just because we don't know the type or dose. There's not studies to support it, but it's something to consider, as well as other medications such as antidiarrheals or antiemetics. Constipation, everybody's favorite topic. So the normal bowel movements are broadly defined as 3 times a day to 3 times a week. So 3 to 21 bowel movements a week. Great. So it varies a ton. It's also defined as the absence of symptoms such as bloating, gas, or pain. Constipation is 2 to 4 times more likely in people with ALS. So we want to assess their medications. Again, if they're on any opioids or iron supplements, if they need stool softeners or laxatives. We want to assess fluid and fiber intake, particularly for people with ambulatory dysfunction. They might be intentionally not hydrating themselves because they have that extra burden of having to get to the bathroom and they're reliant on others. So I think it's just having these honest conversations and saying like, hey, is this a possible reason why you might not be drinking as much as we recommend? We can switch the enteral nutrition formula if needed, working with PT, OT, physiatrist to see if it's appropriate to increase their activity level. And then again, consider probiotic or certain medications to combat the constipation. And then in addition to GI issues, there may be increasing issues with dysphagia and dexterity throughout the disease process. For dysphagia, we want ongoing speech language pathologist evaluation and to see if we need to alter their diet texture. Again, if they start on those more supplemental tube feed, you might need to increase the tube feed as the disease progresses and the dysphagia progresses. We want to determine the reasonable amount and timing of feeds. So like Janae said, it's crazy with these medications and all this MPO time and also their own personal life and impacting their schedule and what time is right for them to get their enteral feeds. And they may require a denser formula or increasing the amount of containers for feed to get to their caloric needs. For dexterity issues, the bolus method again might require too much dexterity, considering other products or administration methods. And then also considering the caregiver needs and the health aides, knowing that health aides technically aren't supposed to give enteral feeds. And so how do you work that when their main support, their main spouse is out working throughout the day and they have a health aide throughout the day that's not a registered nurse, just working with them to make sure that they can get their feeds throughout the day. And I'm going to now hand it over to Janae.
All right, thank you, Stephanie. So we're gonna go ahead and switch about switching from food by mouth to food by feeding tube. So as we see from Stephanie's talk that ALS patients have a lot of weight loss. They're from various reasons, metabolism, lack of appetite, so forth. And to me, due to the fact that the ALS medications, even though there's 4 of them, none of them can reverse the disease. They can't stop the disease. They don't improve symptoms. People can live longer by months, and their progression can be slowed a little bit. But the current treatments so far aren't able to do a lot in terms of the quality of life. So for me, food is like medicine, and so this is a really a passionate interest of mine is what we're going to talk about in the next few slides. One thing, a lot of the neurologists who work with ALS patients may say, when patients are concerned about their weight, is to get their weight up. It doesn't matter what they eat. To me, 5 pounds, gain from Krispy Kreme is not the same as 5 pounds of weight gained in a healthy way, because it can really affect how you feel and your overall health. So whole food ingredients, it can improve tolerance, decrease reflux, retching, vomiting, decrease diarrhea, constipation. A lot of the common food allergens like gluten, dairy, soy, and corn can be avoided. Whole foods are chosen for their proven clinical benefit and are nutritionally complete and have a healthy fatty acid ratio, omega-3 to 6, and don't have any added sugar. So to me, all of these things are going to help patients. As you see with the ALS patients, so many of them have a problem with their gut, their GI, and we've been learning, in the most recent research, that our gut is like our second brain. So it really does affect people's neurological conditions. So there's different ways to incorporate whole foods. You can do it orally through making your own smoothies, supplements, and often I will, when patients start having some symptoms, problems eating, weight loss, I'll send them some recipes on smoothies and also on healthy whole foods that they can add. There's also commercial blenderized formulas, which are formulated with real food ingredients and can contain intact proteins or peptides and are nutritionally dense, with varying from 1 kilocalories per milliliters to 1.5. And that is really important for ALS patients who, again, often have decreased appetite and aren't able to eat a lot. So getting that extra calories in a healthy way is super important. And an alternative to commercially prepared formulas are home blenderized formulas. And often patient caregivers who prefer feeding composed of commonly consumed foods are interested in that. And some important information that is for people who are interested in making their own at home is to just let them know that to be aware of safety guidelines and the potential for nutritional inadequacies. There's actually a blenderized tube feeding recipe builder developed by the Children's Hospital of Philadelphia. And this tool was developed for kids ages 1 to 13 requiring enteral nutrition, but it can be modified to meet the nutritional needs of adults. And the recipe builder guides patients, caregivers in creating nutritionally balanced recipes from scratch. And it can be customized based on energy goals, volume limitations, and allergies. And this is something that I've shared with patients and their families, and it's a great tool for people who are interested in making their own, because a lot of times they're at a loss, and sometimes it's hard to find a nutrition dietitian to who are familiar with ALS. So these are, again, the reasons why I really am interested in promoting whole food blenderized formulas, because of these benefits in terms of decreasing these GI side effects, which our patients often suffer from: nausea, vomiting, constipation, reflux, which can add to increased healthcare costs for treating those problems. and it promotes bowel regularity, increases gut microbial diversity, and also helps with fiber intake. So this was a study to look at 9 studies were included, and 793 participants with an average age of 56 years to 73 years, about the most common etiologies for feeding tube placements, which were neurological impairment and cancer, and to see what the clinical outcomes were associated with blenderized tube feedings. And some of the results showed the continuous decline in anthropometric measures was only evident if there was no clinical oversight. So BTF, which is blenderized formula, was compatible to commercial formulas in terms of body composition, BMI, and weight change. And these results suggest that within a well-controlled monitor environment, BTF does not pose a higher risk for malnutrition than commercialized formulas, which some people are only used to commercialized formulas, so they want to make sure that they're getting the same nutrition. Patients receiving home enteral nutrition were able to gain weight while utilizing a dietitian prescribed BTF. And after converting from commercialized to blenderized formulas, the number of complaints for each GI symptoms decreased, with the greatest improvements in nausea, bloating, and diarrhea. So there's several things that need to be considered when considering blenderized formulas. So one is French size. For homemade blends, a 14 French or larger is preferred, although down to 14 or down to a 10 French has been cited in research. Commercially available blenderized formulas can be used with smaller French sizes, down to 8, depending on the brand. And obviously, following manufacturer guidelines is important. And for adults, this is usually not an issue because normally adults have, I would say, at least around average 20, so that's not as much of an issue as for kids. So although we very rarely have kids also with ALS. The administration method is also important. Bolus versus gravity bags versus pumps. If people do use, we at our clinic use bolus methods since that's the most natural method for eating. But some people do prefer gravity, whether it's for convenience or for tolerance. And for gravity bags, using a large bore works best due to the thicker viscosity of whole food formulas. And another option is reusable tube feeding pouches, such as Bowlies. Now, the pump is probably the method that I use least, just because it's patients, it makes it very difficult for them to do things if they're hooked up to a pump. It's extremely difficult with homemade blends to use a pump due to the thicker viscosity. However, it can be done if you use a large bore gravity bag and reusable feeding pouches or syringes. In general, commercial blenderized formulas, you can deliver it via pump without any additional water, but some others you will need water to thin it out. One thing to really be mindful of when using a pump is that you need to really pay particular attention to the full feeding is given. So for example, if you pour in 8 ounces with a rate of 240 milliliters per hour, stop the feeding when all 8 ounces has been given, and not necessarily at, say, the 1 hour mark, since the rate may not be 100% accurate. So keeping that in mind will help the patient get what he needs through the pump. And keeping in mind as well that priming may take longer with blenderized formulas. and it may be necessary to manually prime. So just letting the patient and family know this information will help them be able to use and be able to get the full advantage of using the pump. Now, with bolus syringe feedings, you may need to use a plunger depending on how thick the formula is. This is especially true for homemade blends, and trying to extend the formula delivery to mimic the length of a regular meal, 20 to 45 minutes, versus trying to get it all in within the 5 to 10 minutes. Sometimes patients and caregivers do, will be important. Other things that I had mentioned before was a reusable bag, like the Bowly bag. You can also get a free arm to kind of hold the gravity bag in place if you need to. Just a couple of things also to keep in mind is that cold formula is thicker, so bringing it a blenderized formula up to room temperature will make it easier to instill. If water is going to be mixed in, actually cold water will make it harder to thin it out versus a slightly warm water, room temperature water. So those are all things that are important to consider. So this is to show that there was a concern about whether blenderized formulas may lead to more tube occlusions versus commercial standardized formula. And this was done with people with ALS and PLS who use blenderized formula. There were 97 tube-fed patients, of which 20% used blenderized, with the average size of 14 to 24 French. The average duration was approximately a year. And despite the perceived risk or worry of feeding tubes occlusions with blenderized formula, there were no occlusions or no more risk than the commercial formulas. All right, so we're going to go ahead with the case studies. So this is a case of a 66-year-old Caucasian female who had a peg tube placed due to progressive difficulty swallowing and weight loss due to her bulbar ALS. So as I had stated, I am very passionate about blenderized formula because it's whole food. So to me, like I said, that is so important to get that nutrition into whole foods. I prescribed normally it's the recommended or average is 4 packets a day, but I start with 2 just because a lot of patients who have weight loss, who have difficulty eating, their stomachs are like balloons. The less they eat, the smaller it gets. And so if they start with 4 packets a day, they're not going to tolerate it. So what I'll do is advise them to start with 2 a day, and then slowly increase as tolerated to 3, and then eventually the goal of getting 4 a day. Sometimes what I'll do is advise to mix each pouch with approximately 4 to 8 ounces of water. That way they get their hydration. It's a little bit easier to administer through the peg tube. And she did very well. She was able to get to the 4 pouches a day. Within a couple of weeks, her weight was stable. She was tolerating it well, had regular bowel movements, didn't have any side effects. So I was very pleased with that. So this next case study will show a little bit more of, we wish probably all patients were like that last patient, but for the most part, we have challenging patients. And this is one case of a patient who I had, who had to get a peg tube due to progressive weight loss, some swallowing difficulties, and after 2 years, with his ALS needed to get the feeding tube. He was really resistant to it at first. I think a lot of people equate feeding tube with decline in their ALS, but I will let them know it's actually to help them maximize their functioning, that they still can eat if it's safe for pleasure, and drink what they would if it's safe, but that way it takes off of that pressure to get the adequate nutrition and hydration, and they can spend that time and energy doing things that they enjoy. So I had to start him on a standard plant-based formula that was covered by insurance. He was attempting to use one container a day to start off with, 4 times a day, but he really experienced a lot of gas, bloating, upset stomach, and constipation. He had a couple times he had yeast, and had problems with getting enough of the standard formula, just because he wasn't able to tolerate it. So I did give him some troubleshooting ideas, which was to increase the feeding time from the 10 to 15 minutes to around the standard meal times. We tried switching to gravity bag versus doing the bolus to see if that would help slow it down, and see if he was able to tolerate with getting some extra hydration in. We tried a peptide base of that formula, and still did not tolerate it. So we were able to switch him to the blenderized formula. And again, with that slow increased regimen as tolerated, he actually did his most of his symptoms resolved. He did still have a little bit of feeling a little bloated, so we did go ahead and add a probiotic that kind of helped with the healing the gut lining, and with that, along with the blenderized formula, he did much better. So Stephanie will go through a third case.
Thanks, Janae. And I don't want to act like any sort of product is all rainbows and butterflies, so I'm presenting both sides of the story, because we know that some patients may not tolerate different to-feed formulas, including blenderized or whole food products, or they might need a combination of different products. So this was a 52-year-old Black male who got a PEG tube due to progressive dysphagia of his bulbar ALS and weight loss, and he got it 6 months after diagnosis. He was still eating at this point, so he was on a mist and moist diet with thin liquids, and so we supplemented with after the PEG tube with 2 containers a day of a standard plant-based product that provided 1.5 calories per milliliter. So this provided about 40% of his needs. He did opt for bolus feeds. I allow my patients, and I send them different videos of bolus versus gravities, and he chose bolus feeds just because he was still getting down to bucket list items in which he was traveling a lot. So bolus feeds matched his lifestyle better, but he was having loose bowel movements, gas, and cramping and bloating and nausea, despite no significant change in his diet. So we addressed the bowels with encouraging him to do some factors of a brat diet, bananas and rice and applesauce and toast and tea when he could. We switched to gravity bags to see if the bolus administration rate was too rapid for him with the syringes. He wanted to try homemade blenderized tube feeds, but given his lifestyle, a lot of traveling, the questionable cuisines is where he was going. He decided it wasn't the best option for him, but he wanted to try a different tube feed. So we did try him on 2 different commercialized blenderized tube feed products. He did okay with these. He felt better, but he still had some nausea, and he was losing weight because of the nausea. So we put him we continued the blenderized 2-feed product. We also added on a standard high-calorie product and then an additional high-calorie supplement that's 330 calories in 1.5 ounces. Still not feeling great, so we did the gravity bags over 30 minutes. Previously, he was doing them over 20 minutes. That seemed to help, but at the end of the day, this poor man just needed some medication. We tried metoclopramide, which we don't love to have in the neurology population. That didn't have any impact, but then we switched to ondansetron or Zofran, and that has seemed to help him the most. So he is on the blenderized 2-feed, the standard product, the high-calorie supplement, on a slower gravity feeds with Zofran. And so not one size fits all, and we are going to open up to some questions.
Great. Thank you both so very, very much. We have several questions here, so I'm going to direct certain questions to each of you to get us started. So Janae, for you, what is the average age for onset of ALS? And if a parent has ALS, do they do any type of monitoring for the children?
So for the average onset, I believe it's around, again, it can be varied, but I would say around 50s is the typical. There's a very slightly higher males and females, but just in terms of parents, if they have ALS and for their kids, it depends on whether they have the genetic variant for ALS. So for example, I think I shared in the original slides that approximately 90% is what we call spontaneous. So there's no known genetic cause for it. 5 to 10% have a genetic familial cause. And in that case, what we do is we provide genetic counseling to give information to the family in terms of whether they want to have testing for the rest of the family, including their children, what the implications are. And in terms of also, there's certain variants that are more predominant in terms of the family members having that versus sometimes you can have a variant and it's not necessarily going to be a cause for concern in terms of definitely having the symptoms occur. So all of those factors play into whether family and patients decide to get testing for their family members, including their children.
Okay, great, thank you. Stephanie, how do you deal with insurance coverage issues with supplemental enteral nutrition?
Oh, I love going to bat with Medicare. It's one of my passions. It funnels my feistiness into a noble cause. I will say, do not use the word supplemental in your notes. Actually, not to plug our website, but to plug our website, alsnutrition.org. We have example verbiage, and I say that they are not meeting their needs. You have to have justification. Weight loss, we have tried different diet textures, different supplements for high calories, and they're still continuing to lose weight. So they need this for it to be commiserate with their weight and strength. That is the term that Medicare is looking for. And then I also note that this is in my documentation that ALS is a progressive disease, so I anticipate them to need more enteral nutrition as the disease progresses.
Great, those are very helpful. Thank you.
I also have a great, I love appeals. So if Medicare still comes back or whatever insurance comes back, we do have an example appeal on our website as well that you can use as a draft.
Great, that's awesome. Stephanie, to you on this one too. Any contraindications with bolus feeds and respiratory function in ALS?
That's a good question, because especially with a non-invasive ventilation, I have some patients that it goes down into their stomach and like the air goes down to their stomach and they get a little bit full from that. I mean, does it increase their risk of aspiration? Possibly, especially if you're not taking measures that they're reclined after the feeds. But I still feel okay with bolusing most of our patients. And they're honestly, if they're going to aspirate, they're probably going to aspirate on their secretions as well. So that's always a current concern. I think you can't ever totally take away the risk of aspiration in this population, unfortunately.
Janae, How often do you follow up with your tube feeding patients, especially if they're having intolerance issues to their G tubes? Like, what's your kind of clinic standard?
Yeah, I think I'm a little bit unique because every single patient has my personal cell phone. So I'm I'm in frequent contact with them, not just about their feeding, but everything. So uh, within 24 hours, I would say even less, if someone has a problem, they contact me and then I'm able to troubleshoot and give them information. On a regular basis, I would say I usually try and follow up with them a couple weeks after they, just to make sure they're doing okay. I mean, I normally our multidisciplinary clinic meets every 3 months, but I am in frequent contact with our patients much more than during that time period because obviously people can't wait 3 months with diarrhea or vomiting or problems. So I'm in frequent contact with my patients.
Okay. And what about you, Stephanie? How often do you generally see your patients for follow-up care?
I'm a rare unicorn that I am employed by the clinic. I know a lot of people are being pulled from inpatient or other outpatient services, but I will follow up within a week once they get home to see how they're doing with their tube feed. I will also say that certain DME companies have dietitians on staff and that provide follow-up. The drawback is that it could be a little bit confusing. The patients can be like, wait, I just talked with my dietitian at ALS Center and now you're calling me. But I do think for those people that don't have dedicated time to follow up with these patients as frequently as we probably should, that you can ask your DME if they provide that service as well to follow up with them.
Okay. And I know everybody, it's a little after our time together. We'll stay on for a few more questions, and then if we don't get to your question, I will try and get these amazing presenters answered and email it to you. So I will say you should have your CPE certificate by the end of the day today, as well as your reference list. Those will come out in email form by the end of business. And up on the screen, if you want to register for our next webinar at the end of February, you can scan that QR code or head over to our website. If you have to jump off, I totally understand. But Stephanie and Janae, do you have time for just a few more questions?
Yeah.
Okay. This one, Stephanie, is for you. What weight do you use if you calculate calories per kg? Do you use ideal, usual, adjusted? If their BMI is for 30 to 35 per se.
That's a good question because that's the BMI we're recommending. I do kind of adjust it down. If their BMI is about 30 to 35, I do adjust it down to 25 calories per kg. Sometimes even 20 depending on how obese they are. But again, I don't focus too much on it just because I know that's just a starting point. So I just do close follow-up and see if that calculation was actually legit or not, or if I need to adjust it.
Okay. And Janae, can you go back over the genetic variants that are associated with ALS? I think that was like on one of your first slides. And while you're looking for that, I can have Stephanie answer a question. Stephanie, what are the changes in micronutrient requirements? Do we need to consider changes in iron and calcium, for example?
I don't know of any micronutrient specific literature that is out there. I know that we've tried to see if different supplements work, but at this point, I don't know if there's any increases in iron or calcium, so I can't speak to that.
Okay, okay. Janae, did you find it?
I will say with vitamin D though, just given that a lot of our patients are immobile, are more housebound, that they are at risk for vitamin D deficiency. So there's that.
Makes sense. Have you ever had somebody with ALS that has that you've had to use TPN for because of any extreme GI issues?
I have, but it was more so because this patient got a J tube given her history of gastric bypass, but the tube kept falling out, possibly being pulled out. And so in that case, she did have to have TPN to cover her nutrition needs while we figured out the tube. But I will say I've never had them for GI issues, usually we're able to adapt the medications or adapt the enteral nutrition formula or diet to compensate for any sort of GI issues.
Okay. And this is I think the
Oh,
last question. Yeah, Janae, are you back? Oh, you are. Good.
yeah, sorry, I lost the audio, so I had to disconnect and come back on. Okay. Did I miss anything important? Sorry.
No,
Stephanie, I'm
the
sure
last,
Stephanie handled it well.
Stephanie nailed it. But the last question for you was just the one about the specific genetic variants.
Yes. What about them?
Can you name them again?
Oh, C9orf 72, FUS, which is FUS, SOD1, and TARDP, I think. Sorry. Those are the most common ones, but again, there's variants, and they're continuing to do research, finding more genetic information, but those four are probably the most common ones. And there's right now the medication, the treatment, tofersen or Qalsody, is specifically for the SOD1. That's an antisense oligonucleotide treatment that's delivered through intrathecal method.
Okay, great. Thank you for that, for repeating that for us.
Yeah, you're welcome.
Last question here is, Stephanie, this is asking in regards to a newly diagnosed patients who are also morbidly obese, so outside that above that 35 BMI range. What do you kind of do in those situations, you know, given the difficulty in breathing from the progression of the ALS and also the difficulty in breathing that sometimes associates morbid obesity? How would you approach that?
Right. I do encourage them for overall general health to eat healthy. With that usually comes weight loss. I do tell them that I don't care about your weight, like really, like as far as physically, like you have ALS, right? Like you have limited time to live, unfortunately. And so I want to take that quality of life factor in, that food really means a lot to some people. But I will say that I will tell them the reality of that it might become more difficult to breathe if you have this excessive weight, particularly in the abdominal area. It might make transportations more difficult, make you more prone to falls. So I do tell them my goal is to healthily lose weight around a pound a week, doing adequate protein and more fruits and vegetables. But then if the weight loss becomes out of control, like we are going to stop, and I give them like firm parameters, like this weight range is where I want you to stop. And it's in that BMI 30 to 35 category.
Yeah, I think that's a beautiful answer. It's tough. This is a tough population, and you both are amazing clinicians for advocating for these patients. So, and thank you so much for your time today, sharing your knowledge and passion with the group. We will close it out here, but like I said, I thank you so much from the bottom of my heart for you guys taking your time to do this. So,
thanks for having us.
All right, thank you. Have a good day.
bye, everybody.
Bye.